welcome to our last DTx webinar of 2024. Thank you to those that have attended our previous 5. So today's final session is going to be case examples of DTx and a panel discussion. And we have 3 presenters today, Dr. Eliane Boucher, Dr. Dunn, Dr. Glenn. This is a free educational event. It's brought to you by Louisiana Department of Health, Office of Behavioral Health, and Northeast Delta Human Service Authority, and Foundation for Wellness. It is accredited for 1 hour for AMAPR Category 1 credits, nurses, LPCs, and social workers general credit. Full participation of this presentation is required to receive credit. In 1 week, you'll receive information from info at Foundation for Wellness with instructions on how to get your certificate. If you dialed in by phone, meaning you're using the audio on your phone, not the Zoom phone app, please email info at Foundation for Wellness. And in that email, please include your first and last name and the phone number you dialed in with. So on to financial disclosures. Activity Planning Committee and Physician Planner have no financial disclosures. Our speakers did disclose some things, so I'm going to read that to you. Dr. Eliane Boucher is a full-time employee overseeing program of research for Twill, Inc. DarioHealth has recently acquired Twill, and thereby Dr. Boucher is currently employed full-time under DarioHealth umbrella. Dr. Jessilyn Dunn has disclosed a scientific advisory board member position with Very Inc. Dr. Jordan Glenn has disclosed he's a recipient of salary and stock options at Chief Science Officer of NeuroTrack and a recipient of stock options as a scientific advisor to Toy Labs. So I'm going to read a little bit about each of our speakers. The format of today's webinar is each of our wonderful speakers are going to give a very brief presentation of who they are and a little nuggets of information for y'all. And then we're going to open up the floor to discussion. The Q&A at the very bottom is available to you. So please address your specific questions in the Q&A at the bottom. And so after all the presentations, we will get to all your wonderful questions. So a little bit about our 3 speakers. Dr. Boucher earned her PhD in social personality psychology from Queen's University in 2009, where her research focused on the intersection of social psychology and mental health. She currently serves as the Senior Director of Behavioral Health Science at Twill, where she oversees the program of research, analyzes consumer data to derive insights for product optimization, and serves as a scientific advisor. Dr. Jessilyn Dunn is Assistant Professor of Biomedical Engineering and Biostatistics and Bioinformatics at Duke University and Director of the Big Ideas Laboratory. She is currently PI of the BARDA-funded COVID-identity study to detect and monitor respiratory infections like COVID-19 using mobile health technologies, and an NIH-funded study to develop digital biomarkers of pre- and type 2 diabetes. Dr. Dunn was postdoctoral fellow at Stanford and an NSF graduate research fellow at Georgia Tech and Emory, as well as visiting scholar at the U.S. Centers for Disease Control and Prevention and the National Cardiovascular Research Institute in Madrid, Spain. And for Dr. Glenn, as NeuroTrack's Chief Science Officer, Dr. Jordan Glenn leads the company's scientific development and validation pipeline while informing the company's business development partnerships. He also holds an academic dual appointment at University of Arkansas and has been authored on over 100 scientific publications. He is also primary investigator on the DC Marvel project. Jordan holds a PhD with specializations in exercise physiology, genotology, and nutrition from University of Arkansas. So wonderful background from all our speakers. We are going to start with Dr. Boucher. So Kelsey, can you share your screen and we will get started.
Thank you, Ashley. And while Kelsey gets it up, I guess I can get us started. So thank you everyone for joining us today. I'm really excited to be back. You might have tuned in a few weeks ago, I guess maybe a month or so ago now, when I actually led a session on equity in digital therapeutics. So I'm really excited to be back and kind of dig in a little bit more into a particular area that I think I briefly touched on in that previous webinar, which is really the concept of using digital therapeutics with older adults, something that has historically not gotten a lot of attention. But I think we're all starting to pay a little bit more attention as we have kind of this silver tsunami headed our way, and also an aging population that is becoming more and more familiar with technologies. So I think, Kelsey, we can go to the next slide. So this was already mentioned, but I'll just kind of reiterate again that I'm currently full-time employed by DarioHealth, but DarioHealth acquired my former employer, Twill, which was formerly known as Happify Inc. So that is currently where I work and hold stock options. And the research that I'm briefly going to discuss in regards to digital therapeutics in older adults was sponsored by Twill and is on their product. So we can go to the next slide as well. So I think why I wanted to talk about this briefly today, and if you're joining us in person, next month, I'll actually be digging into digital therapeutics with older adults more deeply in a session at the in-person conference that the Foundation for Wellness is doing. But essentially, although we have lots of opportunities with older adults as we think about this growing aging population that really has many needs, both in terms of health-related needs, but also mental health-related needs, and in particular, loneliness, which has been a major focus with an aging population in terms of their well-being and their social belonging, but also because loneliness has major physical implications as well for physical health. But interestingly, when we think about this burgeoning world of digital therapeutics, there has been very, very little attention devoted to this population. And I think some of it comes from a bias that the older adults just aren't into technology, or they're not as familiar with technology, that has led people to not really think about this population specifically, but also a little bit of hubris that this is a population that can be harder to recruit. And so the research hasn't focused on this particular population, but yet products are sometimes sold for this population, even though the evidence base isn't really there to support whether digital therapeutics work in an older adult population. What we need to recognize is that even before the pandemic, we had an aging population that was becoming increasingly familiar with technology. So, my mom is part of this population now, and she is someone who has not grown up with a computer like me or a smartphone, but has become incredibly familiar with how to use a computer, who has a tablet at home, who has a smartphone. That's not true of all older adults. The proportion of older adults, particularly once you go over the age of about 71, 75, drops compared to the general population. But we'd be remiss to not think that there are opportunities for digital therapeutics in this particular population. That being said, when we think about 50% of digital therapeutics or DTx studies have an upper age limit that really exclude people who would be part of this older adults age group. We don't know if the research that we've done generalizes to this population, especially because there are unique needs. What research does exist shows that older adults are actually interested in digital health. They want to start to manage their own health from home. They are becoming increasingly comfortable with digital technologies. This is particularly true post-pandemic, where your grandmothers had to learn how to use Zoom in order to communicate with their families and friends. So we are talking about a post-pandemic world where older adults, even those who weren't necessarily familiar with technology beforehand, have had to become familiar with these technologies in order to stay connected. And what's really interesting is there's some preliminary research that shows that although adoption rates of digital therapeutics are lower among older adults, once they adopt the technologies, they might actually be more engaged than younger users. They might be more likely to use those technologies as recommended, be more likely to be retained users, so on and so forth. So this is a population that, while the barrier is getting them to adopt the technologies and start to use them, they might actually be a really great audience for digital therapeutics. So where I'm going to spend the rest of the time, and Kelsey, you can go to the next slide, is talking about a retrospective study that we ran to look at how our older adult population was engaging with our well-being product. So this is a well-being product that is a self-guided digital therapeutic that is available both B2C, so direct to consumer, but also available through employers or health plans. And when we look at our audience, we tend to find that we have kind of this inverted U on age and adoption, where from about 18 to 24, we have lower levels of adoption, as well as 65 and older. And really the kind of large bulk of our population of users is coming in that 25 to 45 range. So really kind of middle adult, young adulthood to middle adulthood. So what I wanted to do is really understand how are older adults engaging with our product, and more importantly, are they actually benefiting from our products, to understand whether even if adoption rates are lower, when they adopt the product, are they actually starting to improve? Are we showing similar improvements in this older adult population than we see in other cohorts? So we conducted a retrospective analysis of 375 users, real world users who identified as being 65 or older when they started using our program. And we looked at changes in both well-being, subjective well-being, user proprietary assessment, as well as anxiety as measured by the GAD-2 over time and based on their level of usage. And what was really interesting, and this isn't on the slide, was we found that essentially when we compared levels of usage between this older adult population and our other age cohorts, we found that about 30% of our users were engaging optimally, which for us means completing an average of 2 or more activities per week. And that was comparable to what we've seen in other retrospective studies that didn't include older adults. So while we aren't finding that older adults are engaging better, we're finding that on average, they are engaging in the same way. So they are a receptive audience once they adopt the technology. We also found that when they are engaging optimally, they are showing significant improvements in their well-being above and beyond what we see among the users, the older adults who are engaging less. So we saw an average of about 24.5% improvement in their well-being scores over time, compared to about just under 12% among those who completed fewer activities. And this was a significant improvement and a significant difference between those two bars as well. On the next slide, you'll see a really similar graph for anxiety, except now the slopes are going down because we're looking for a reduction in scores for the GAD-2. And what we found again was that when they're engaging optimally, older adults are seeing a significant improvement in their anxiety symptoms over time, almost 26%. And this was significantly greater than what we saw among those who were engaging below that optimal level, who were completing fewer activities, who saw about a 10.5% improvement over time. So I don't want to take too much time, and I'm happy to answer any questions after that, but I want to leave you with a few thoughts about older adults and digital therapeutics on the next slide, Kelsey. So I think when we think about digital therapeutics for older adults, this is an area where the digital therapeutic industry, but practitioners alike, really need to start spending more time thinking about what this looks like. We know that this is a receptive audience once they adopt these technologies. And we know by and large, we need to test this with more technologies, but we know that when they engage, they are going to improve the same way that we might see in a younger cohort. So it's not a matter of these technologies might not be suited to older adults, but there are main barriers that we really need to think about, and adoption is really one of those. So what we do know is that older adults tend to be less familiar with these digital technologies. When they've done qualitative research that looks at why older adults aren't adopting these technologies, it's often that they either don't know about the technologies, they don't know that they exist, and they're cynical about whether or not they would work. But when they're presented with the programs, with the technologies, they actually tend to have very favorable opinions. So what it means is we really do need to spend more time educating older adults about digital therapeutics. We probably need broad education across the board, not just for older adults, but this is a population that's less attuned with what technologies are out there, which means the industry, society, practitioners all need to think about this, about how to introduce these technologies to older adults who might be good candidates for the different digital therapeutics that are out there. The other issue to consider is that even once they are familiar with them and willing to give them a try, what we know is that there are still many older adults who struggle with some of the basic concepts of how to use technology. So they might be less familiar with how to go and download the app. They might not understand how to open the app and go through the onboarding procedure, which means that even when you get the interest, you're more likely to lose them along the way before they even actually start engaging with the app. And even once they've onboarded and they've signed up, they may not understand how to engage with that app properly. And again, this is probably something that everyone could benefit from, but we should have a particular eye on a population that is less technology savvy than younger cohorts. So we should really be thinking about support that we can provide for older adults as they start using these digital health technologies, as they download the app, as they sign up, as they start using the programs. And there's been some really interesting advice and work that's come out of John Torres's lab talking about digital navigators that I think would be really pertinent in an older adult population. And for people who are starting to think about digital therapeutics, particularly aimed at older adults, I think this is something they should really bear in mind. The final thing I want to talk about is that as we think about older adults as a specific population we want to target for digital therapeutics, we really do need to start thinking about ways to tailor our programs and our products for that population. They have unique needs that goes beyond not really being technologically savvy, but they have cognitive and physical abilities that might deteriorate over time. So that means really thinking about that population in terms of if you've gamified aspects of your program, maybe you need to rethink if parts of that gamification need to be adapted, need to be slowed down. Your text might need to be larger. Your contrast might need to be different. It goes beyond just swapping out the pictures in your product, for instance. So really thinking about adapting a product when you're targeting an older adult population and making them part of your design, centering their needs and their experiences. And I really think that co-design is where that happens. So those are the last three thoughts that I just kind of want to leave mulling in your head. Happy to answer any questions afterwards, but don't want to steal any time away from my co-presenters today. So thank you for tuning in. If you liked what I talked about today, definitely join us in person next month, and I will stick around for questions.
Awesome. Thank you so much. Dr. Dunn, Kelsey will be sharing her screen shortly, and we're ready for you.
Great, thanks so much. I think I was able to share, if you all can see my slides.
Yes, we see your slides.
Great. All right. Thanks so much. So I'm thrilled to be following Dr. Boucher and talking a little bit more about sort of the research underlying the development of digital biomarkers. So in this portion of the talk, I'll explain some of the terminology or lingo around what it means to be a digital biomarker. Before I dive into that, just financial disclosure, not super relevant to this talk, but I am a scientific advisor to Very Inc. So what sort of motivates the work that I do in my lab at Duke is these ever-expanding options for measuring biosignals. So a lot of the work that we do is how we take the data that comes from different wearable devices and turn that into something meaningful that can lead to actions, whether that's actions taken by a clinician, actions taken by a patient, or just actions taken by everyday people to optimize their health. And what's really interesting about the time that we live in is that the ability to measure biosignals or information coming from our bodies is only expanding. We have smart textiles now. We have paintable electronics. So you can really imagine the variety of different measurements that we can take about our body continuously over time. And so I think the most common method that we think of is maybe the smartwatch, where we have heart rate being measured, step counts being measured, but this ability to measure is only expanding. So when I talk about a biomarker, a digital biomarker, the idea here is that we're measuring some digitally collected data. So that could be a continuous heart rate over the course of a day, a month, a week, a year. It could be continuous location information. It could be physical activity or sleep information. And we take that data and use mathematical transformations. So machine learning is a great example of that, different sort of statistical models, and relate that data to an outcome of interest. So for example, whether or not somebody has an infection, whether or not somebody has diabetes. And so the idea is that we're trying to leverage information that comes from these wearables to better understand somebody's health state. And the details of what that looks like under the hood are that we have a lot of large data that we're working with. We work with clinicians who bring medical domain knowledge, and then we perform a lot of statistical analysis and development of mathematical models in order to develop these digital biomarkers. So I will talk at the end of this talk about one specific example of that. But before I talk about the specific example of a digital biomarker for COVID-19, I just want to mention that there are some challenges that come with discovering digital biomarkers and with implementing them in real-world settings. So accuracy is a big issue that we like to think about, and understanding how accurate the measurements that we are taking are, that the models that we're developing are. Also comparing that accuracy to human accuracy, because we know that humans also have the ability to make errors. And so when we're looking at sort of the relative accuracy between digital biomarkers and human decision making, we want to weigh that differential effect. We also want to make sure that the models that we're developing are interpretable. So if we have a model that says that somebody is likely to have a COVID-19 infection right now based on their wearables data, we want to know why that is. What about the data that's being fed in is indicating that likelihood? And part of that is making the information underlying these following what we call FAIR principles. So findable, accessible, interoperable, and reproducible. There are also regulatory concerns when it comes to setting these digital biomarkers into real-world use, figuring out how to use the massive amount of data that's coming in, whether that's bogging down clinicians, whether that's bogging down people. How can we consolidate information to make it easy to digest? There are also issues around privacy and ethics, including this phrase ELSI, ethical, legal, and social issues. So there's a lot that goes into thinking about a digital biomarker. What I want to talk about next is one of the examples of how a digital biomarker can actually be really useful in practice. So I hate to say during the COVID-19 pandemic, because this is really kind of an ongoing situation that we have a current wave going on right now. I just had COVID last week. So this is, we are still living in this world. And interestingly, this issue of diagnostic testing shortages continues to this day. So last week I went into a CVS to try to get a COVID-19 test, and there was one test left on the shelf. And we know that this was a problem early on in the pandemic, and as waves of COVID hit, we continue to see testing shortages. So one of the questions that we asked in my lab was, is there a way that we could use information that's coming from smartwatches to better decide who needs a COVID test so that we could allocate these limited resources more intelligently? So what we did was we first defined the problem. We said if we have fewer tests than we have number of people who we would like to test, how do we allocate this limited number of tests such that we optimize the chances of catching somebody who actually has COVID? And so you can see if we were to randomly allocate the test, we would only catch sort of a lower number of people than if we had some prior information that could enable us to intelligently allocate who gets a test. So what we saw was that using smartwatch information based on physical activity, this is step count here, and based on resting heart rate here, we can see that prior to people getting a test, and this is data from hundreds of people in our study, there was a difference in these biosignals. And based on that, we developed a machine learning model that could tell us who would be the most appropriate to give a test to maximize the positivity rate. So that if we only have a few tests that we can use, how do we maximize the benefit of those tests? So this is just one example of a digital biomarker that was developed through an academic study, and that is, working in practice and continuing to be developed. And we have an open source software project that we've been working on with the broader digital biomarker community, which is sharing the data, code, algorithms, and educational resources for digital biomarker development. So if you go to dbdp.org, you'll see a lot of sort of introductory materials and blog posts to get started in this field. And you can also share some of the projects that you might be working on. And so ultimately, our goal is to use digital biomarkers to enable patient empowerment, precision therapies, just-in-time interventions, and improved access to care. And with that, I'll be glad to hand this over to Dr. Glenn, who will round out these talks.
Awesome. Thank you, Jessilyn. Your Big Ideas Lab, does that stand for something, or is it just the fun name?
Believe it or not, it does. We are the Biomedical Informatics Group, and the ideas is integrating data engineering and analytics. When we work in the NIH realm, we're used to having a lot of acronyms, but I get a lot of flack for having too many acronyms. So sometimes we just go with big ideas.
I like it. I like it. Yeah, I have a part of a study that we called the DC Marvel study, which was we started with the acronym and worked our way backwards. So I like that stuff. Okay, so Kelsey, I'm gonna share my own screen if you don't mind, just simply because it'll be a little easier for me to control my talk track. So Jordan Glenn, I'm the Chief Science Officer at NeuroTrack Technologies. We focus on integrating cognitive testing into healthcare. And so what I'm going to do is talk a little bit about the problem with cognitive testing in the healthcare space, and then work that we did, kind of a case study, for lack of a better word, on how we work to overcome a lot of the barriers associated with traditional healthcare to begin to then integrate these types of technologies into day-to-day activities and day-to-day clinical workflows. Happy to be here. I was in a past life as a professor at Louisiana Tech University, so anytime I get a chance to talk with groups down in the Louisiana area, I'm a big fan. So let me see here. I won't talk about this. This is just like, NeuroTrack has been around for a long time, about 10 years, and we have focused on cognitive assessment and Alzheimer's specifically since our inception. We did my disclosures early. So what is the problem? The problem today when it comes to cognitive health is that dementia is one of the single most expensive conditions to care and treat for in the United States. We know that the average lifetime cost of care gets over like $400,000 for people. Women are 3x likely to develop Alzheimer's disease. We see significant increases, and especially we believe to be changes in hormonal levels after menopause. We see increased ER visits, et cetera. And so it's not just somebody starts to lose their memory and they're at home and they're being cared for. There's so many other complexities that come along with it. And so really to treat dementia, you have to first be able to find it. You have to be able to identify it, especially early on in the disease state, to be able to properly manage it. But that's really hard. And I have no doubt that many people on this webinar today either have somebody in their life that has gone through this process, or friends or family members that they've seen go through it. And if you have, you know that it can get really messy. But if we don't know how to identify it to begin with, it becomes really, really difficult to manage long-term. And so that's where we wanted to start, is with cognitive testing. We know that 96% of primary care providers say cognitive testing is important, but that barely 15% of our seniors actually get tested. And so why? There's so many barriers that come into place, whether that be time, part of routine clinical workflows, no assistance, no help, confidence in the ability to actually diagnose a condition, or even use testing to identify a condition. And so when it comes to building out digital therapeutics, it's a lot more than saying we have this cool thing, we did the science behind it, and we know it works. There's that entire series of barriers to come after with how do we actually make it flow within our healthcare system. And that's where a big part of my job is. It's not only the validation of our technology, but also the strategy and the process of working with our healthcare system, working with providers, all the way from the medical assistant, on the front lines, through the finance people at the top that have to pay for these type of technologies, to figure out how do we overcome the many, many, many barriers associated with incorporating these things into healthcare today. And so I like to, when we start with what needs to be considered, I like to call these things the ways to be told no. And we've been told no every which way you can imagine over the years. And so you continue to work through and figure out how you have to essentially surmount each of these barriers individually. And so we think about things like cost or complexity to implement. Everything is going to cause burden on the system. How do we fit it within clinical workflows? For any of you that work with healthcare, you know that on a day-to-day basis, there are policies, procedures that need to be followed. Sometimes it's as simple as writing the thing on the Post-it note and handing the Post-it note over, but that's the process. And that workflow is built in. Every clinic is different. Every system is different. And so anything that's built for this population or this group needs to be able to fit kind of ubiquitously within these different workflows. Something I like to call the sniff test. If it quacks like a duck, if it walks like a duck, it's probably a duck. You're going to get a lot of that. Even not just the science providers across the board are going to say, like, I don't know if this does what I think it does, just because it doesn't feel right. It doesn't quite look right. So it needs to pass that kind of muster as well. Technology flexibility needs to be able to be integrated in a lot of different ways to maximize the different ways that systems like to handle testing or work with their patients. Especially these days, we need to really focus on inclusivity. We know that we need, like, especially with cognition, if you come from Black, African-American, Hispanic background, white, Asian, we see different trends. We also can't just assume everybody knows English. We can't just assume everybody is going to be able to look at a cognitive test and be able to walk through it if they come from different backgrounds, different languages, ethnicities, et cetera. And then finally, interpretation. Is this difficult for doctors to interpret? Can we do it for them? How do they get this information? And then what do they do with that information? And so we have to solve all of these problems. So number one, cost, complexity, and clinical workflows. We learned that we either have to be able to have something that's completely integrated into the EHR, where you literally scan a QR code and everything is pumped into the system, all the way through day one, where you are, writing things on a Post-it note and handing it back and forth, and everything in between. We still use faxes in the US. It's really hard to get anything. If you use Epic or Athena, it's really hard to get anything integrated into those systems because of the IT burden and overload that most systems are on. So being able to not only figure out the cost, but figure out what level of complexity can each individual clinic or each individual system handle has been something that we've had to really, really focus on and kind of be able to boil the ocean, for lack of a better word, in order to make sure that when we show up and we want to implement, that we can meet the system or the clinic where they're at. The sniff test. Does it feel like a cognitive test? If I go in and I put this in and we start to use it in the day-to-day workflows, is it going to just piss people off? Or are they going to be like, actually, this helps me. I like this. Are they going to give positive feedback back up the chain to say, like, we should keep this thing in? Because no matter how good a product is or a therapeutic is, if it doesn't make the lives easier of the people using it, it's not useful. And it's not going to make any difference when it comes to the day-to-day. And so really focusing on how do we make it patient administered, so that way we don't take burden and time from the providers. How do we make it a very simple single data point? How do we make it so it instantly can go into the EMR? And so we've been able to save 10 minutes a patient. We make sure that 90% of the MAs, the medical assistants, who are the ones doing the work on a day-to-day basis, they find it easy to use. Most people say it's easier than some of the things they were using before. People say it's fast. We call those things the sniff test, because at the end of the day, like I said, no matter how good it is, if we can't make people's lives easier with these products, and that's just not patients, it's the providers too, it's the entire workflow, the entire system, it's not useful. Flexibility, and this is where we kind of incorporate inclusivity as well. So we work with a senior population, and I think Eliane did a really good job of talking about how we need to be focusing on these individuals. And so some of that is absolutely being able to make it work in clinic, but also how do we make it work at home? How do we make it work if they're in a virtual environment? Can we make it where it's a single click and somebody who might have cognitive impairment in their 60s, 70s, 80s can actually use this product? Because if it requires any sort of installation or download or signing in, they're gone. We lost them. And so making it super easy for it to be administered right there in the clinic when somebody's coming in, or at home before they come in the clinic. So that way that score is already sitting in the system. So all of those different environments have to be accounted for. And we've had to account for those different environments in order to make this work ubiquitously within these settings. And I think that that's final. Yeah. So the final one is the interpretation. And so at the end of this, if you've worked in healthcare, you've probably worked with many different vendors who will pop out these 30-page reports with all this information and data. And you're like, what do I do with this thing? And it can get really difficult. And so we have to take what is a very complex process and cognitive assessment and all the data points and all the information that we're collecting and distill it into a score or a report that a provider can quickly look at, interpret, understand, and know, what do I do with this patient? Can I send Edward home, or do I need to refer out to a neurologist for follow-up steps? Do they need to retest? Do I need to have a further conversation with the family? We need to help them make those decisions without them needing to read through page after page after page, because they don't have time to do that. And so making sure that we are providing very quick, very easy scores that are that are quick to understand. How do they get this in the EMR where they can refer back to it later and be able to track their patient over time as well. These kinds of things go through many, many different iterations. So that way we make sure that this can be done almost instantaneously by the providers, so they don't waste a lot of time doing other things or trying to interpret things, so they can move on with their patient, but also the next patient they're inevitably going to have in line as well. And so we take into account all of these factors. We actually create a digital therapeutic product that can work in healthcare. Some amazing ideas in digital therapeutics have failed simply because they can't fit within the non-science or the non-efficacy barriers that healthcare presents. So it has, being able to create routine, inclusive, high integrity products that can be used quickly and objectively without a ton of training, because there's also a ton of staff turnover in these clinics. And you have a product that actually can be utilized on a day-to-day basis, and not only within one clinic, but within many. And that's been something that we focused on, something that we have really hammered on over the years to make sure that we can incorporate regardless of the system, regardless of the workflows that we work within. So this is just maybe my own PSA. The prevalence of Alzheimer's is decreasing rapidly. You'll have access to these slides, I'm sure, but you can see isolated into the southeast region of the country, the southern, the Midwest region, we see a lot of these issues. This is personal to me. I went to school in Arkansas. I lived in Louisiana. I grew up in Florida. So just a PSA to be aware, to be careful, and to be keeping an eye on your loved ones. So thank you with that. And I'm happy to also take questions like the rest of the panel as well.
Thank you so much to our speakers. I want to open the floor up to questions from our audience. Okay, if you have any questions, please use the Q&A. To get the ball rolling, we prepared some questions. I do want to ask Dr. Glenn and anybody else who want to jump in, could you share a case example or success story where digital therapeutics have significantly benefited a patient with OUD? What were the outcomes achieved?
With OUD? I'm sorry, I don't know. What do you mean by OUD?
Opioid use disorders.
Oh, I'm not an opioid expert. I'm a cognition expert. So maybe that's not quite right question for me.
Has anybody can share case examples specifically with OUD?
I can jump in and not speak to a specific case example because it's definitely not an area that I have worked on. But I will say that we had a pretty solid example that came out of Paratherapeutics. Now, unfortunately, and Ashley, I was talking about this with you, unfortunately, Paratherapeutics is a company that did not make it, but their Reset and Reset O was specifically focused on opioid use disorder, was successful, and it was FDA cleared. So it was a really great example of a digital therapeutic making it through the FDA process to actually be a prescription digital therapeutic that could be used to support people with OUD. My hope is that what we're seeing right now is prescription digital therapeutics are really, really tough in the market. Payers have been struggling to offer reimbursement. They're wanting to see a higher level of evidence, particularly when it comes to ROI. So because of that, a lot of payers, even though you've got an FDA cleared prescription digital therapeutic, haven't been following through to offer reimbursement, which means the onus is then on the patient to pay for these technologies, which are unusually expensive. Like one of the difficult things for digital therapeutics is you have to convince someone, a patient, a user, that this app that's on their phone where they can typically get apps for like free or $10 a month might cost them $1,500 a month, or not $1,500 a month, $1,500 for a course of treatment. And that's a really difficult pill to swallow, to use kind of a term. So I think what's unfortunate is the technologies exist to support OUD. They are based in evidence, but we are having a hard time getting them into patients' hands because of this reimbursement issue. So what I'm hoping is that we can all work together. Digital Therapeutics Alliance is doing some great work here to start moving the needle on that. And then I think we'll see more people starting to focus on this population again, because ultimately a company needs to be able to keep the lights on to offer these programs, right? And so.
Thank you so much. Thank you so much. I have another question. How can healthcare professionals stay informed and adaptable in their approach to integrating DTx interventions into their practice as technology continues to evolve?
I can touch on that a little bit. I think a big part of it is, so these days there's probably a therapeutic that exists for almost any pain point that, could be found within health systems and clinical workflows. The big one, I think, is to where we're moving away from as a space is away from point solutions, meaning like we have to have something for this little thing or this little thing or this, and more into all encompassing models. And so I think that's probably as much time as I spend working with healthcare providers, usually where I recommend, or they tend to keep an eye out, is what are the big, not like I want another way to do blood pressure, but what are the big problems I'm facing in my day-to-day workflows? What are it could be billing, it could be, referrals. There's a lot of different areas that encompass much more larger components. And those are the areas that I think are likely to become more prominent and become more useful, are the area, one company that can kind of do it all, for lack of a better word, instead of these individual. You're not going to have in a meeting or a patient visit 10 different individual things that somebody's going to be expected to use because the system breaks immediately. So I think those are the areas that encompass much larger things that can clean up workflows as opposed to add more complexity to them, are the areas I would stay focused on.
Okay, audience or our attendees, if you have any questions, feel free to put them in the Q&A or chat. Okay, so we do have some questions. Where can I find information online for the clinics that utilize NeuroTrack? I see Dr. Lenz typing something in. But if you also want to share with the rest information online for clinics that utilize NeuroTrack.
Yeah, so I'm happy to talk live. So by all means, visit neurotrack.com, the website, but also probably easier to just email me directly, Jordan@neurotrack.com. I'll write it in the webinar chat as well, so everybody can have access to it. And then I can make sure to direct any questions about the company within. So very, very easy to do.
We have a question. Is there any emphasis on how the more vulnerable elder populations will gain access to these programs that can improve their health or access to care?
I'll jump in and just say that I think we're seeing a greater emphasis on how digital therapeutics can be applied in this population. And I'm not sure what we mean specifically by vulnerable elder population, if we're talking about the kind of older adults as being vulnerable as a whole or a particular subset. But what I have seen in my kind of work-related conversations is groups like AARP are becoming interested in this and sharing information with their members. We're seeing a lot of payers who are starting to pay attention to digital therapeutics when it comes to Medicare, for instance, as making it part of their benefits. So I think when we think about access, particularly going to the challenges of reimbursement, when we think outside of reimbursement, how do we allow people, particularly people who have SDOH variables that might make it harder for them to pay out of pocket, to access traditional care, so on and so forth? The way to get this in the most people's hands so they can start to benefit from the variety of therapeutics that are out there is to make this part of their Medicare programs, is to make this part of other things that they're already participating in, whether it's AARP or other systems, and to make it affordable or reimbursable. So I think we're starting to see movement in that direction. And I hope that with positive results that start coming from kind of early adopters, that we'll see kind of renewed interest and increasing interest with these populations.
Yeah, I think that I couldn't agree more. I think, and Courtney, to your point, I see a lot of we talk a lot about people who live in the more rural areas that may not have access to these types of care, and that's kind of part of what I put into the case study is we had to figure out a way to do it remotely. So we know somebody on Medicare is required when they go in for their annual Medicare wellness visit, they're required to have a cognitive assessment done, but it was being done something like 16% of the time, even though it was an actual requirement as part of the CMS mandate for Medicare. Why? Because people don't have access. Like if they're going to see their PCPs in these, I lived in Louisiana and I lived in Ruston, in some of these rural areas where you may not have these very, prominent hospitals. The technology is not there. And so that is the biggest thing, is figuring out how we take this technology and make it where people can take it in the comfort of their own homes, where they're not driving 2, 3, 4 hours to go get a 3-minute, 4-minute test done, but they can do it at home. And if there's there, if we see, some sort of issue, we actually make it worth the patient's time to come in. And so being able to start to leverage, I think, telehealth, digital health, virtual health more, which it's a barrier because systems don't get paid the same way to do it. The codes have changed over the years. They're kind of held up on sticks right now. And so if they go away, it's only going to get worse. But it's these kinds of things that have to continue to push forward. But it's also on technologies like us to continue to make the technologies accessible. If the technologies are there, if they work, if they're accessible, it's much more likely that the codes and the billing reimbursement process will stay in place. So I definitely think there's a bit of like a give and take to this. As long as the technology is there, people will be able to figure out one way to pay for it at some point.
What opportunities exist for collaboration between healthcare professionals and technology developers to optimize the design and delivery of DTx interventions?
I mean, I can answer all of these, but I want everyone else to be able to participate. So maybe I'll touch on it quickly. So we have programs at NeuroTrack where we set up no-cost pilots with health systems, where we come in and we'll work within a clinic or a couple of clinics, come and meet the MAs, work on like a short-term implementation of how it would look in a very quick setting, to show how easy it is to implement across systems. So some companies will do that, some won't. That's been a big thing for us, is sometimes we'll set them up as research studies where we'll come in and we'll learn. We'll sit down with the doctors, we'll sit with patients, MAs, and we'll learn what works, what doesn't work. Where are you getting caught up in your workflows, those kinds of things, because then we can go back and optimize. Because again, at the end of the day, our job is to make it easy for patients and providers. And so we will set up a lot of different things like that with smaller clinics or systems or individual one-offs, just to be able to learn. So some companies will do that. I don't know everyone who does, but we absolutely do love doing those kinds of things with healthcare partners.
Yeah, one thing I can mention on the development side is that we do quite a bit of work with clinicians. So, here at Duke, we have clinicians that are clinician researchers. They a lot of times bring problems to us that they see in the clinic, and we as biomedical engineers will try to develop solutions to those problems. So we work iteratively, where we are brought problems, we work to develop solutions, and then we implement those solutions in the clinic. Usually as a first stage is research and see how things actually work. But I think that iterative back and forth process is really important to ensuring that, we as engineers are designing things that are actually useful in real clinical practice. So it's challenging, but it requires a lot of communication and a lot of learning to speak the same language.
Yeah, and I'll just jump in to add that I just believe that co-design is always important. Ultimately, whatever you're designing some kind of a tool, a program to solve some problem. And if you're designing a digital therapeutic that is meant to be implemented with a provider, with a practitioner, you are not only solving a problem for their patient, as Dr. Glenn said, you're solving a problem for the physician, for the provider, for the practitioner. And so you need to involve them Otherwise, you can miss the mark. You can make assumptions, but you can miss the mark. But also, if you involve them as co-designers, you have buy-in, and you have people who can speak the language to help get buy-in from other people. And I think that's a mistake that we often make, is we don't always invest in the co-design part because it can slow things down. But I do think that that's a major differentiator. If you can work with the people that you are trying to target, they are going to be your best resource in building something that they're going to want to use and that's going to work.
What are some common barriers or challenges faced in the implementation of DTx programs, and how can they be effectively addressed? I know you guys had talked about some barriers earlier, but can we just touch on that again, and how you can address those common barriers?
Well, I'll say that, I mean, I talked about a number of them. I think if I was to pick one that is the biggest, it's clinical workflows. Like, it doesn't matter if it's going to, like, when we go into systems and if we go in and we say, hey, we're going to, we have this thing, it's only going to take your providers 3 minutes. They're out the door. They're like, I'm not giving you 30 seconds. Our providers are already so underwater. They're so burdened. We're trying to fit more patients in, not less patients in what we have going on. And so any sort of digital therapeutic product, it cannot change clinical workflows. And if it does, it has to make them faster somehow. And that is, I think, the number one question we get asked across the board after, does the science work, is how does this affect my clinical workflows? And we lost, a lot of deals early in NeuroTrack's career just by, we weren't quite there yet. We didn't quite understand how that worked. And so by doing a lot of what we're talking about, the co-design, sitting with providers, working in clinics, making sure that we truly understand how these things worked, we are able to create an environment where it actually can fit in. We have a saying at NeuroTrack, there's how healthcare is supposed to work and then how healthcare actually works. Most digital therapeutics are built for how healthcare is supposed to work. And really everything needs to be built for how it actually works. I've seen, I was in an office not long ago where somebody had written a patient's medical number, medical MRN on a Post-it note, threw the Post-it note away, had to go into the trash can, find the Post-it note because she typed it in wrong. Like, that's the reality of how these things happen on a day-to-day basis. And so you have to be accounting for these things that you're never going to see in a spreadsheet, you're never going to see in a document, but how the actual process works on a day-to-day basis. I think that's the biggest barrier to overcome, especially in US healthcare.
I guess from my perspective, the biggest barrier that I view is, especially in the wellness and the mental health space, there are just so many apps out there. It's like the Wild West, because when you can qualify as a wellness app, you're not regulated. So it's kind of like you're the over-the-counter vitamins of the digital health world. And anyone can build an app and put it on the App Store, and they make these wild claims. And there's actually research that shows that very few of them are evidence-based, even though they say they're evidence-based. Very few of them have evidence to support them. So as someone who is trying to adopt these technologies, it's very difficult to even just know what you should use, what differentiates the good apps from the bad apps, what makes something worth paying versus using it for free, what's actually effective, what's been made more specific to a particular population. It's overwhelming. And I think people give up, or they go for the big names that are out there that have spent a lot of money on marketing, that have puzzles and teas and all kinds of things in stores. And I think what we've seen is a couple of academic labs, Dr. Schuler, Dr. Torres, have both built tools that are meant to help people make sense of this, help practitioners who are supporting patients make sense of this. But neither one of those seem to have become really disseminated, really user-friendly. And so for me, this education component and this differentiation of what is evidence-based, what is effective versus what is just another app that's been added to the App Store that is making wild, baseless claims. Figuring out a way to do that that's user-friendly is probably one of our biggest barriers, because for every user and patient that uses something that isn't good, it's just a bad taste in their mouth about the whole field, right?
Yeah, we have a comment, so many apps and it's overwhelming. Indeed, it is. And I think it's like that. I feel like across the board with so many things, the more information, the more things out there, the more confusing it is to the user and how to weed out what we should use, what we shouldn't use, what we should believe, what we should not believe. So yeah, I totally see how that is a struggle from y'all's end as well, but then as a potential user as well, to get that education out there. What should we really be doing? But we are at time. I want to thank our three panelists for their brief presentation and taking the time to answer questions.